So we start with a 4 team, and then against team we have 3 rounds each. Okay, so the first one is 3 minutes for the facts. Okay, are you guys ready? Yeah.
Hi, so good morning everybody. So my name is Alvin from Singapore. I'd like to introduce my team. This is Vano from Cambodia and Chris from Hong Kong. So today we're going to argue for the in the topic of bladder cuff management and whether total robotic nephroureterectomy should replace the standard open cuff excision. So I would like to begin by saying that the bladder cuff management is actually one of the most crucial steps of nephroureterectomy and remains the standard for all high-risk upper tract urothelial cancers. Complete bladder cuff removal decreases the risk of intravesical recurrence within the intramural ureter, and traditionally the standard of care for upper tract tumors, especially for locally advanced cancers, is an open radical nephroureterectomy, and this is advocated in the European guidelines. However, if you look closely at the guidelines and when the references were from, they're actually predominantly from the past decade, and most of the studies that evaluated the oncological outcomes were from more than 10 years ago, likely in the laparoscopic era, where open were compared to the laparoscopic techniques, and likely these surgical techniques and surgeon experience was not as well developed as it is now. So with the evolution of and with the advent of the robotic surgical platform known as the Da Vinci, from the S to the SI to the XI, in the earlier descriptions of robot-assisted nephroureterectomy, the kidney part is traditionally performed laparoscopically, and they actually have to turn the patient to the lithotomy position so that they can dock the robot between the legs so that they can perform the bladder cuff excision robotically. And in these cases, there's a lot of time that is being spent to reposition the patient from the flank to the lithotomy position. And once the XI system came into the arena in 2014, the overhead boom of the robotic arms enabled features such as camera hopping, multi-quadrant access using targeting and retargeting options from the robotic platform, and the patient clearance allowed the surgery to be performed in a single position, which is a lateral position with the bed broken. So I think Prof. Patel has actually published several papers in 2015 and described this technique as an evolution from SI to XI, and a single position is used to, and this dramatically reduce the operative time from a median of 232 minutes to 184 minutes in his paper. So other than that, the robotic platform gives us 3D visualization of the vesical-ureteric junction, allowing for better visualization of the vesical-ureteric junction as we dissect to the bladder cuff. And also with the endo-wrist technology, this allows for suturing of the cystostomy site to be more ergonomic to the surgeon. And we all know that this is one of the most difficult parts of the surgery for an open bladder cuff excision, especially if the bladder mucosa is retracted and we cannot visualize the mucosa for approximation of the cystostomy site. Okay.
Time's up for the first team. So you ready?
So good morning, I'm Ivan from Hong Kong. To start with, UTUC is a relatively rare disease with only 2 cases per 100,000 person years from SHEAR database and only 5% of urothelial carcinoma. It makes this as a limited clinical trials and evidence, and among them, 1/3 of them is a ureteric tumor, and most of them, 70%, are at distal ureter, and there has up to 10% concomitant UTUC with CA bladder. And the standard treatment must obey the oncological principle, which consists of a complete en-bloc resection of the kidney, the ureter, excision of a bladder cuff to avoid tumor seeding and to minimize spillage. The open bladder cuff approach can allow the conform to oncological principles, and also to confirms that there is a complete excision and accurate histological examinations. While the total robotic approach will encounter difficulty in conforming the aforementioned oncological principle, and a risk of leaving behind the ureter and bladder cuff segments, particularly in distal ureteric tumor and cases with concomitant bladder tumor that may require TURBT. I agree that it is technically feasible, but the outcome is still preliminary. There are data showing robotic approach has similar oncological outcome, but then is limited by the fact that these studies are retrospective in design with its own limitations. And long-term follow-up was not yet reported in these studies. In conclusions, the preliminary outcome of robotic procedure could be promising and attractive, but it could be safe in certain cases, but it cannot replace all cases, particularly in distal ureteric tumor cases or cases with concomitant bladder tumor. Thank you.
Is there time? Or you want to pass over to them?
I'm Dr. Milan. I'll be continuing with the talk. Regarding the oncological outcome of robotic surgeries, we'll always be talking about bladder cuff excision and the intravesical reoccurrence of the tumor. And in those studies that have been shown, those were retrospective studies showing the similar oncological outcomes. But there are papers regarding creation of pneumoperitoneum and tumor spillage, intravesical reoccurrence, tumor seeding, and related to pneumoperitoneum, which could be of gravitational spillage or effect. And there has been a meta-analysis, though there were no studies related to robotic, but in this study they have shown laparoscopic nephrouretectomy is a factor, treatment-specific factor, with extravesical bladder cuff excision is one of the component for intravesical reoccurrence. And I'll be even talking about the cost.
So you have about 4 minutes to discuss whatever the other side has said and move on with okay.
For the next part, you can continue selling why we think it's
Hello.
better. And then the only points that they have so far is that they say that there will be
There's no spare mic, they only give to
Hello.
This was yeah. But we still to sell a point. We just want to sell whatever good things that we have, we can sell for apart from that.
Hello. Check 1 2. Hey, 1 2.
We focus about oncological outcome only, and then whatever data they have, they will present like oncological outcome.
Okay, so we have the 4 teams again.
Okay, I'm Chris Wong from Hong Kong, Chinese University. I learned a friend over there mentioned 2 points that supported open bladder cuff excision. One of it is a open bladder cuff excision helps us confirms a negative margin status, and the second point is an open method can reduce tumor spillage, but we think that both of these points are not valid or supported by evidence. First of all, as for margin status, according to a very updated single cohort retrospective study by Tertiary Center that compared 130 cases of open nephroureterectomy versus total robotic nephroureterectomy, it was actually reported that the margin positivity is much lower in the robotic group compared to the open radical group of 1.5% compared to 15%. Although caveat in that it's basically they are different operation because it's comparing a radical open nephrourectomy versus a robotic approach. So it's not like limiting the comparison to the bladder cuff management, but we can at least say that we cannot, and there's no evidence to say a robotic approach is inferior to a open approach in terms of margin. And second point they mentioned about it's the possibility of tumor spillage. In fact, with a better visualization from a robotic system, it's even actually postulated that the opening of the urethral orifice and the bladder cuff could be minimalized in a controlled manner. And there's, in fact, no evidence to suggest that the tumor spillage is worse in the robotic group. In fact, if we consider, for example, evidences in the long-term survival outcomes, latest meta-analyses actually at least demonstrated comparable recurrence-free survival or cancer-specific survival when comparing robotic versus open nephrourectomy. So both of these points, as from our point of view, they are not supported by evidences. And in fact, we believe that the robotic group is at least comparable, if not better, to the already available evidences from the open bladder cuff management. And another potential benefit from a robotic bladder cuff management was some novel case reports. There have been reports about same-day discharge nephrourectomy utilizing total robotic approach. For example, in this updated case report, they mentioned this patient undergo a nephrourectomy for a renal pelvis tumor, subsequently put in a Foley's catheter and then discharged same day. So we believe that this is only possible in a robotic but not a open approach. Thank you.
The other side, okay.
What my friend has said that there is less risk of tumor spillage during the procedure. Here I am talking about not during the handling, but due to the effect of pneumoperitoneum. Okay, that is a fact. In case of laparoscopic or in robotic, where pneumoperitoneum is created, that will lead to gravitational effect, leading to tumor seeding in the site. And regarding the papers, what he has come up, I would like to say that these all are retrospective studies. There is no meta-analysis or randomized prospective studies in comparison with robotic surgery and open surgery, and these are single institutional. There is no multi-institutional data, and these study, they have been biased. There has been selection bias in terms of comparison with open group. They have like low, those cases with no lymphovascular invasion or low-grade tumor, those cases has been compared. So, and the other point is regarding the operating time. Okay, though there has been change in robotic system from XSI and XI, so that previously they used to undock while changing the position and all, and that could have led to trocar site implantation as well. But now, since they are not doing it, but while changing the position, though it is not done now, what we do is like we change the instrument. So like that could also lead to a longer operating time, though this is not that significant. And regarding the post-operative pain and length of hospital stay, though robotic is good at doing that, but there has not been that significant outcome as compared to oncological outcome of open surgeries.
And Thank you for the reply and very good points about the outcome of the robotic NU versus open. And I think it's good to point out that it is a single core trial, and also a retrospective design, limited case number 131. And also it is a non-inferior trial, which was not trying to prove which one is more superior. And I believe we have already reached a consensus that there is none superior to one method is superior to each other's, and only in selected cases then we can pick a better option for the patient, and therefore it should not replace open cuff excision.
Okay, so we go to the last round of finish off with the 14 again.
Okay, I'm Manel, and when we talk about the robotic nephroureterectomy, and it's about operation time, that it's not it's better than it's better than open surgery, and it was significantly shorter for the robotic nephroureterectomy at 5 days if we compare to open surgery for 10 days. So it half time lower. And about the hospital stay, and about the complication for the surgery, as the if you for me, as I come from a developing country, if I open the surgery, the complication is for open surgery is more complicated after the surgery, because sometimes like infected wound infection, so the patient need to stay longer in hospital and need more management than nephroureterectomy by robotic, because you need to have more medication for the patient, like such as antibiotic for the wound infection, something like that. And the blood loss for the nephroureterectomy robotic is less. Is if you compare to open surgery, 150 compared to 250 ml. In summary, the total robotic nephroureterectomy should be replaced the standard laparoscopic and open surgery, because it better cuff decision and closure of the cystostomy through better visualization and surgeon ergonomic, shorter operative time due to less need of repositioning, lower positive surgical margin rate, no evidence to show inferior oncological outcome, better peri-operative outcome such as less operative complication, less blood loss, and shorter length of stay in hospital. Thank you.
Okay, good. Last round to impress your judges.
Hi, I'm Alex. I'm from Singapore. I think at the end of the day, we are talking about UTUC. We're talking about bladder cuff management, and we all know that it's important to obtain good surgical outcomes because the risk of recurrence within a residual stump can be as high as 30 to 65%. So with that in mind, why would we choose open rather than robotic? I mean, simply because, you have mentioned things like operating time maybe shorter in your robotic procedure, but there are case studies and retrospective studies that also show that op time is shorter in open rather than laparoscopic, and versus open versus laparoscopic. The hospital stay and blood loss you've also mentioned that is longer in open surgery, but at the end of the day, to us, our concern is the surgical outcomes for the patient, right? And we know that in obtaining that surgical margin of the bladder cuff excision is the most important part, especially in cases with distal ureteric tumors. My friend here has mentioned that up to 70% of our UTUC is in the distal ureter, and as such, obtaining that margin is extremely important. And for cases with concomitant bladder CA, you also need to do a TURBT. So I guess robotic may have a say in future, But as of now, I think open is still the gold standard to go to in terms of bladder cuff excision and obtaining those good margins in order to give the patient the best standard of care. In addition to that, robotic also incurs a lot of costs. Not every institution has a robot to be able to perform that, so we also have to take that into consideration when we are considering offering such a treatment to patient as well. At the end of the day, robot is expensive. There's not enough long-term prospective evidence to prove that it is superior to open at this point in time. As such, our stance is still that open should still be the mainstay of treatment for bladder cuff management. Thank you.
Anything else? We still have about a minute or so to add on to just
I think through this debate, we have seen the good points of robotic surgery and also its limitations and also the limitations of the current evidence. And I believe we can make conclusions that there is no one technique that can replace all other techniques at this moment. But we can see the preliminary outcome of robotic surgery is very promising. And we hope with a future RCT that can give us the answer on and give us a conclusion to this debate. Thank you.
Okay, so that's the end of the first two debates. We give a hand applause for all the participants. But I think for now, I would like to ask the preceptors and the judges if anything to comment at this stage. Anyone? Any of the preceptors or any seniors want to comment on the...
I'm Dr. Milan from Nepal.
I'm Ivan from Hong Kong.
Ivan from Hong Kong, okay.
Alex from Singapore.
Alex from Singapore. Alvin from there.
Alvin from Singapore.
Wanel from Cambodia.
Chris Wong from Hong Kong.
So I think if nobody has anything else to add, we can have a lunch break now.